excited to be here for session number 4 of AYAO Power, which is our adolescent and young adult program for oncology workforce education and resources. This session, like I said, is our 4th one, which we're very excited about. As a very quick reminder, we will not have a session next month as we take a break, but we'll be starting off strong in January for several more months, so stay tuned for that. Just a very few quick housekeeping things for us. As always, continued thanks to Doctors Mike Roth and Scott Merdler for their partnership and the AYA Oncology Education Working Group for connecting with Elephants&tea and bringing this amazing program to everybody here. All of our sessions are recorded, so going to remind everyone of that over and over, that everything is on demand on our website. So all of the talks are available, additional resources are available, landmark articles are all available. So there's a great hub of resources on our website. If you did attend our session last month with Dr. Bober, there were some talks about some handouts of hers that she was hoping to share, and those are now up on our website as well. So if those were something you were interested in, please check those out. The chat feature is available as always through the webinar, so feel free to connect. We love to see the discussions going on there. And the Q&A will also be available for a wonderful discussion with our presenter at the end. And with that, I'm going to pass it off to Dr. Roth to get us introduced to our speaker today.
Thank you so much, Kayla, and thanks to everyone for joining us. We have a wonderful speaker today on an incredibly important topic that is relevant to all of the patients we serve, and we're just really lucky to have Dr. Appiah with us. So very brief introduction. Dr. Appiah is a professor of obstetrics and gynecology, and she is the chief of the Division of Academic Specialists in OBGYN at the University of Colorado School of Medicine and Children's Hospital, Colorado. She is a fellowship-trained pediatric and adolescent gynecologist and director of the Fertility Preservation and Reproductive Late Effects Program at the Comprehensive Cancer Center and Center for Cancer and Blood Disorders. Dr. Appiah is an international expert in the field of oncofertility and is committed to ensuring all young patients with cancer receive fertility counseling and access to fertility preservation. With that, I will hand it over to Dr. Appiah and just thank you so much for joining us and for educating our group.
Thank you so much for having me. It is my absolute pleasure, and thank you for the introduction. I am going to share my screen here, and you get to see everything I do while I share it. All right. This is a topic that I am very passionate about, and so that is my one disclaimer, I think, that I'm very passionate. Here we go. Okay. So in terms of disclosures, I have no disclosures or of interest to disclose, no conflicts of interest to disclose. For the objectives, my hope is that this group at the end of this conversation will be able to explain risk factors for ovarian and uterine injury after cancer therapy, be able to discuss current and emerging fertility preservation therapies, and then be able to describe barriers to reproductive late effects care and some strategies to improve outcomes using an equity lens. There are estimated to be 2 million new cases of cancer in 2023, and your group would be familiar with this. Approximately 10,000 of those cases is predicted to occur in the pediatric population between 0 and 14 years, about 5,000 in the adolescent population, 15 and 19 years, and about 80,000 in the young adult population between the ages of 20 and 39 years. The 5-year survival rate has improved to about 84–85%. This is a significant improvement in terms of the AYA population specifically. Survival rates 5–10 years ago were much lower. But due to a focus on this population, we've been able to increase survival rates. So there are estimated to be about 100,000 survivors of reproductive age annually due to our improved therapies. So with survivors living longer, it is estimated that up to 3/4 will experience long-term adverse sequelae of cancer therapies termed late effects. The cancer care paradigm has thus shifted to include a focus on quality of life in survivorship And this includes a focus on early screening of these late effects, prevention of long-term sequelae, and implementation of evidence-based guidelines for symptom management. And then current endeavors also include minimizing collateral damage to normal tissues through targeted therapy and eradicating cancer through gene therapy. Reproductive late effects are an often undiagnosed and undertreated consequence of cancer therapy. Acute gonadal injury affects 12% of pediatric patients who receive at-risk therapies, and including primary ovarian insufficiency, and about 66% of males who receive at-risk therapies as children are going to experience Sertoli cell dysfunction and therefore have problems with fertility. Genital graft versus host disease is a condition that is not widely appreciated in patients who undergo stem cell transplant, but it does affect 50% of that population. So we're all familiar with graft versus host disease, but the genitalia can also be affected. Radiation-induced uterine injury affects about 30% of patients who receive either total body irradiation or pelvic radiation. And patients who receive pelvic radiation also have an increased risk of radiation-induced vaginal stenosis, so our female patients. Sexual dysfunction is a significant concern in the adolescent and young adult population and affects about 50% of patients treated. The majority of the data that we have regarding fertility outcomes in cancer survivors is in our childhood cancer survivor population. So when I showed you the data that 12% of children, female children who receive at-risk therapies will have infertility, this doesn't include the patients who are 18 years and older. And this is the first study published by Anderson and colleagues where they really looked at this young adult population, 18 to 39 years. And what they showed is that these patients are going to be almost 40% less likely to conceive compared to controls. So if we look here, the blue line are our controls and the red line designates patients with cancer. And then the y-axis is probability of pregnancy. So it's about 40% difference. Hodgkin lymphoma, about the same, so 40% decreased likelihood of fertility. When we look at patients with leukemia, we see that that delta is greater. The reason is that many patients with leukemia will unfortunately go on to bone marrow transplant, which infers or incurs a higher risk of infertility. In addition, this population tends to continue on maintenance therapy for many years, and that can affect their ability to proceed with fertility. The delta is even greater in patients who have brain or CNS tumors. The reason for this is multiple. So these patients undergo surgery to the brain, and that affects their ability to partner sometimes with individuals to even then move on to a romantic relationship. And then the therapies that these individuals receive include radiation, which can affect the hypothalamus and pituitary, which then results in infertility in these patients. So how do we quantify risk when we have a patient with a cancer diagnosis? So this slide is meant to remind us of the process of follicular loss. And I'm going to go through it for the individuals who are not gynecologists. So for female patients, we are born with the complete complement of follicles that we're going to have our entire lives. So we're born with about 2 million eggs. Over time, we lose those eggs to atresia. So 90% of follicles are lost to cell death, and then 10% are lost through ovulation. And monthly, we recruit about 1,000 follicles. When we receive chemotherapy, all chemotherapeutic agents are going to affect the rapidly dividing cells, which include the follicles that are growing and producing estrogen. So these patients will stop having menses during cancer treatments. And then when that insult has been removed, although there may be a decreased follicular pool, there's still plenty of eggs available for patients to ovulate and conceive. When patients receive radiation or alkylating agents specifically, which affect cells that are at rest, these patients are the ones that we're most concerned about and the ones that are going to go on to experience infertility. So like individuals who receive adriamycin, metabolites, and those sorts of things, these patients will stop having periods during treatment, but many of them will not resume menstrual function. And I bring up the menstrual function because many times it can be an inaccurate indicator of fertility for us. So we tend to think that if patients are having menstrual cycles, and that means they're fertile, and that's not the case. What a menses tells us is that today they may have some fertility, and even then, all bleeding is not ovulatory bleeding. So I want to make sure that the audience understands when we see patients in survivorship, we really want to assess their ovarian function through laboratory evaluation and not go on their clinical presentation in terms of their long-term fertility. It's helpful to stratify risk by treatment. The therapies that we are most concerned about in terms of fertility are those alkylating agents that patients receive. Medium risk categories for our patients include cisplatin and carboplatin in our males. We have found that this is not concerning in our female patients. And then low risk therapies are the antimetabolites. And then the unknown risk are these newer therapies, the monoclonal antibody therapies, the tyrosine kinase inhibitor therapies. We are not quite sure what the impact on fertility is for these therapies, and studies are ongoing to assess. We believe that based on their mechanism of action, they have a lower risk, but we don't yet have the data to confirm that. It's also helpful to stratify risk by diagnosis. When we have historically looked at risk, we have high level of increased risk, significantly increased risk, and minimally increased risk. High level risk is greater than 80% chance of acute ovarian failure. And what that means is that within 2 years of treatment, these patients will lose fertility completely. The moderate risk category here, significantly increased risk, has a broad range of 30 to 70% likelihood of losing fertility within 2 years of treatment. And that range is broad because it really depends on the age of the patient and how much therapy they receive. And then minimally increased risk is less than 20%. So again, patients who receive alkylating agents are going to fall in this higher risk category. So we think of our patients with Ewing sarcoma, pelvic radiation, total body irradiation, and patients who have Hodgkin's lymphoma and are still receiving alkylators such as EPOC and CHOP. And then conditioning for bone marrow transplant typically involves several alkylating agents. And so we know that these patients are going to be at increased risk. Patients with AML, breast cancer, osteosarcoma, due to the type of therapies they receive, have a moderate risk of infertility. And then our patients with leukemia, germ cell tumors, and Wilms tumor are considered minimally increased risk. The caveat with this group is that some of these patients do go on to receive therapies that will cause them to move from minimally increased risk to high level. So as we know, patients with ALL can progress to bone marrow transplant. And so when we see these patients, we counsel that they are at minimally increased risk based on their current therapy, but should they progress to a bone marrow transplant, then they'll be considered high risk. And we will need to see those patients again in the middle of their therapy to determine which options are available to them. Wilms tumor patients many times receive abdominal pelvic radiation. So chemotherapy alone places them at minimally increased risk, but the radiation will move them over to a high level of increased risk. How do we actually calculate risk? So cyclophosphamide is the referent alkylating agent that all alkylating agents are compared to. So when we see a patient, we determine which alkylating agents they're going to receive in milligrams per meter dose as the total cumulative dose. And then we just simply plug this into a calculator, which then gives us a total CED. So the cyclophosphamide equivalent dose is what we are using to compare all therapies. We have a risk stratification tool that we use that is based on the CED that can help us to stratify these patients when we see them. And we have stratified patients based on pubertal status for females. The reason, again, is that female patients are going to be born with the full complement of eggs for the entire duration of their lives, and then we're going to lose those eggs over time. So we can tolerate more chemotherapy in our prepubertal state than we can in our postpubertal and adult state because we have fewer follicles to recover as we age. So when I see a patient, we will determine the cutoff. So the cutoff for a prepubertal patient is 12 grams per meter squared. If a patient receives that much chemotherapy, then we know based on the data that they are at high level of increased risk of acute ovarian failure within 2 years of treatment. Pubertal patients may tolerate less chemotherapy before dipping into that or tipping into that high level. So our pubertal girls, 8 grams per meter squared is too much, and they're going to be considered at high level risk. In terms of radiation, age again is protective in our female patients. The cutoff is 15 grays for highest level of increased risk for our prepubertal girls, and then 10 grays for postpubertal. We offer fertility preservation for patients in both of these categories, significantly increased risk and high level of increased risk. Depending on which category they fall into, we will lean more towards one or the other, and we'll talk about that in a moment. Our male patients are not have more sensitivity to chemotherapy and radiation than our female patients. So these patients tolerate far less chemotherapy than our female patients, and age does not confer protection. The younger the patient, that is not more beneficial. And the reason is that our male patients are able to produce sperm throughout their lifetime into their 70s. And so the injury may occur now, but they may recover over time based on their ability to produce additional sperm, and really based on how much alkylating therapy they receive. So the cutoff for our male patients is 4 grams per meter squared. If a patient is receiving that much chemotherapy, then we're going to offer fertility preservation. Stem cell transplant, as I stated, for both our males and females, are going to place them at the highest level risk of gonadal dysfunction, and we will offer fertility preservation in that patient. Again, cisplatin and carboplatin are not considered gonadotoxic in females, but it is dose dependent for our males. So male patients who receive greater than 500 milligrams per meter squared of cisplatin are going to be in the significantly increased risk category, and then radiation as well. For our older patients who undergo retroperitoneal lymph node dissection, that is going to affect the nerve and vascular bundles. So those patients are going to be at significantly increased risk. So we will offer fertility preservation to any male who is going to fall in this category. And to be fair, because banking sperm can be fairly straightforward depending on how sick or well the patient, any male patient who wanted to preserve fertility would be offered the opportunity, but we're going to specifically emphasize that for patients who are significantly increased risk or high level increased risk. So if we know that patients are at risk and we know which treatments cause risk, what do our guidelines recommend in terms of how we should be caring for this population? So there is no organization in reproductive health or oncology that has not put out guidelines regarding how we should be caring for these patients. So the Fertiprotect network is an international network that has put out a part 1 and part 2. So indications for fertility preservation and then fertility preservation techniques. The American Society for Clinical Oncology has also developed guidelines, the European Society for Human Reproduction and Embryology, and then the American Society for Reproductive Medicine. So we know what we should be doing for our patients. And what these consensus position statements say is that physicians should inform cancer patients about options for fertility preservation and future reproduction prior to treatment. Once patients receive chemotherapy or radiation, then our options are significantly limited. So our male patients cannot bank sperm, they cannot undergo testicular tissue freezing. Our female patients cannot freeze eggs, and we're left with ovarian tissue freezing in that population. So the takeaway point from this slide is that we need to see these patients for counseling prior to treatment. And really, as soon as the oncologist has a concern about a malignancy, we need to see the patients. Because in that time that your team is confirming the diagnosis, confirming the treatment plan, the patient's receiving a second opinion, we could have moved forward with fertility preservation so that once the diagnosis is confirmed and you're ready to start therapy, there isn't a conversation about, can we wait another 2 weeks for our female patients or not? This conversation should occur regardless of the patient's age, gender, culture, socioeconomic status, or healthcare team bias. We have options for prepubertal, postpubertal males and females. So age should never be a hindrance. We have options for patients from different cultural backgrounds. Religious considerations are extremely important during this conversation. There are some individuals who are going to be prohibited from pursuing specific fertility preservation options based on their background and religious beliefs. And so we need to be open to that and not make that decision for the patient. Socioeconomic status is also an area where we sometimes put our biases. Many of our patients who come from a lower socioeconomic status may not be offered fertility preservation because of the concern that they may not be able to afford it. But patients sometimes have the means of identifying those funds, whether it's a family member, whether it's a GoFundMe account. Institutions are becoming much better at identifying philanthropy to support these patients. And so every patient should be offered a consultation with our team. And then healthcare team bias also falls into prognosis. Many times patients with a poor prognosis may not be referred for fertility preservation discussions because the thought is that it's futile. And it really depends on the patient's age and really what the family want. Patients who are 18 years and older may elect to participate in posthumous reproduction. And what that means is that they can decide that their gametes, their eggs, their sperm, testicular tissue, ovarian tissue can be used by another individual. Children cannot make that determination. Parents cannot make that determination for children, but individuals 18 years and older can make that determination. For our younger patients with a poor prognosis, for many of the families, this is an opportunity for them to have hope, and it allows them to think of the positive potential outcome of the treatment, as opposed to hearing there's a 30% survival rate. You know, they think they have stated and expressed that it is helpful to be able to pursue fertility, or at least hear the discussion. And so our job is to offer that to the patients, and then they can decide if they want to pursue that or not. And the last takeaway from this slide is that these conversations need to continue throughout treatment and survivorship in a manner appropriate to the patient's developmental stage. What that means is that treatment options may change. So patients with ALL are considered low risk until they aren't. And when that changes, we need to be able to see the patient and say, you know, now that you are moving to a bone marrow transplant, we really want to discuss ovarian tissue freezing with you for our female patients. And so many times we will counsel our patients directly to reach out to us directly and say, my treatment is changing, I want to have a discussion. And to also have that discussion with their oncologist to remind them that our fertility preservation team stated that we would come back and see the patient if their treatment changed. My very last takeaway for this slide is that the studies do show that patients recall this information better and feel better about this discussion when the discussion occurs with a reproductive specialist. So all oncologists are aware of the risk to fertility of cancer treatments. However, patients need to have the discussion with a reproductive specialist who can really speak intelligently about the risks and all of the treatment options and the benefits and success rates. And so the studies show that patients need to have this discussion with the reproductive specialist, and that is a recommendation from the guidelines. Despite the guidelines, less than 50% of patients recall having a discussion with their healthcare provider. Some of that is background noise. They hear a lot of things, so they don't quite remember that they had the discussion. But when the data was further analyzed, many times they don't have the discussion at all. And then less than 50% of patients who do have the discussion go on to pursue fertility preservation therapies. And there are many reasons for that. The biggest reason is going to be cost. The second reason is that patients are afraid to have any delay in their therapy, despite what we know about the safety. And the third is worrying that treatment to stimulate eggs in women, particularly, is going to worsen their prognosis. So the problem stands that despite established guidelines, implementation is not standardized. And this is where we really need to start moving beyond what should we be doing and how should we be doing that. So some of the barriers to implementing these guidelines include provider knowledge, provider bias, costs, and available fertility preservation services. In terms of provider knowledge, we know that 90% of oncologists agree that fertility preservation counseling should occur. However, only about 44% refer, and that's due to concerns about safety and cost and time. Religious considerations, as providers, we need to be aware of what some of those limitations might be for patients. And our job as a reproductive specialist is to know this information and to be open to a discussion with these families. Many times families will pull their religious leaders into the conversation, and we need to allow space for that. In terms of provider bias, we know that almost 50% of oncologists refer male patients more than half of the time, whereas only 12% refer females more than half of the time. And again, this is due to the idea that it is easier for a male patient to bank sperm than a female patient. And then once patients do undergo this counseling and decide to move forward, only 30% of males will pursue fertility preservation, and about 10 to 25% of females will pursue this. And this is a national number. I'm proud to say that at our institution, 86% of males pursue fertility preservation and 40% of females pursue. Cost is probably the biggest barrier to all of this. There are only 12 states with insurance mandates for fertility preservation. Colorado is one of them. I'll show you the next slide that shows the other states. Medicaid overall does not cover this. Utah is the only state where Medicaid covers fertility preservation and fertility services. But interestingly, in Utah, there's no coverage from the private insurers. Women from ethnic backgrounds are less likely to have access to any specialized fertility preservation treatment. And this stems from biases about whether or not women of color will be able to afford these options. And then also it comes from patients' fear of moving forward and not having the appropriate counseling. And then we know that full-scale fertility preservation services are unavailable at many medical centers, and that perhaps is second to cost is likely the greatest barrier. In terms of states with legislation, 12 states have enacted fertility preservation coverage, and as I stated, Utah has Medicaid coverage. So we still have a long ways to go in terms of getting other states to move forward in this area. So then once a patient, we know the patient's risk, we've counseled the patient that they should proceed, what are the options that are available to them? We have standard options and investigational options. Standard options include egg freezing, sperm banking, embryo freezing. And egg freezing is an option for adolescent girls. It is no longer just limited to adult patients. And so we will freeze eggs in patients who are 13 years and older. It does take a mature patient to really go through that process. Oh, I'm so sorry. Ovarian transposition is moving the ovaries from the pelvis above the pelvic brim for patients who are receiving pelvic radiation with success rates of 60 to 90%. And then ovarian tissue freezing, I put this in red because prior to December 2019, it was considered investigational and is now considered standard of care. The investigational options include freezing immature eggs, freezing testicular tissue in our prepubertal males, and then ovarian suppression, which I'll talk about with the next few slides. I do want to just emphasize that immature egg freezing is where the majority of the research is focused right now, because what this allows us to do is forego the 12 days of stimulation that a patient would need to freeze mature eggs. So typically when we say a patient's going to freeze eggs, they basically are going to self-inject with hormone therapy for 12 days to allow the eggs to grow. We're then going to remove those eggs from the ovary before ovulation and then freeze them. But the 12 days can sometimes be prohibitive, especially if a patient has leukemia or lymphoma with a mediastinal mass and needs to go to therapy quickly. So we really want to be able to just remove immature eggs from the ovary without stimulation, and then stimulate those eggs in the lab. And that's where the majority of the research is focused. Testicular tissue freezing in prepubertal males is considered investigational because no sperm is present. We can freeze testicular tissue in postpubertal males because sperm is present, and we'll just freeze the sperm and the tissue. But in prepubertal males, there's only been one live birth, and that is in a non-human primate, so in a monkey. I'm excited to report that on Friday, my colleagues at Pittsburgh did proceed with the first human procedure. And so we will know in the next 9 to 12 months if this is going to be something that we can start to offer as clinical care. And then GnRH agonist suppression, again, I'll show that in the next slide. My takeaway from this slide is that 12 days for stimulation and retrieval is something that is very feasible for the majority of our patients if we're contacted early enough, and then there's no delay. And I also want to emphasize that stimulation can occur at any time in a patient's presentation. Historically, we believed that patients needed to be stimulated on their menstrual cycle, but that is no longer the case. We have random start protocols. So I can see a patient today for a consult, and they can start stimulating for oocyte retrieval tomorrow, and the time is shortened. And I've not seen many cases where we haven't had that time, except in patients with leukemia and some lymphomas. What are the indications for ovarian tissue freezing? Because this is what many of our patients are utilizing for fertility preservation in the pediatric and adolescent space. So patients who are going to be at high risk of gonadal failure after treatment, so anyone in that middle category and to the right, we are going to offer ovarian tissue freezing. The absence of previous high gonadic toxic chemotherapy. So ovarian tissue freezing is the one and only fertility preservation option that we can utilize when a patient has started chemotherapy. For all of the other modalities, the chemotherapy will incur DNA damage immediately, and those follicles and those spermatids will result in miscarriage, fetal wastage, and malformations. When we freeze ovarian tissue, we destroy the follicles that are growing, and the only follicles that remain are those very immature follicles. And those follicles, either it's an all or none phenomenon. They're either going to undergo apoptotic death or going to survive. And they have not incorporated DNA damage because those cells are not rapidly dividing. So a patient may receive 1 or 2 cycles of chemotherapy. We can then remove an ovary and freeze it. And this has been really important in patients with leukemia because there's some data to suggest that leukemic cells can be found in ovarian tissue. So it's actually beneficial to those patients to receive 1 or 2 cycles to potentially eradicate any leukemic cells from the ovarian tissue before we remove it. We also use ovarian tissue freezing in patients with sickle cell or other non-malignant disorders where they're going to undergo stem cell transplant, and then patients with gender and sex diversity or genetic predisposition to accelerated follicular loss, so essentially galactosemia, or patients with Turner syndrome or mixed gonadodysgenesis. So how do we do ovarian tissue freezing? We will remove 1 ovary typically. There are some institutions where they will remove strips of ovarian tissue only. And the idea there is that they want to leave behind as much ovarian tissue as possible. There is a different camp of individuals that I'm included in where we're only offering ovarian tissue freezing for patients in the middle and higher risk category. Therefore, we need all the tissue that we can obtain so that they can have future fertility. So we always remove an entire ovary. And then we remove the cortex from the medulla. The teaching currently is that there are no follicles in the medulla and that all of the follicles are in the cortex. There are some investigators who challenge that and wonder, should we not be keeping this medullary tissue for future reasons? So once we remove the cortex, we are going to transect the cortex into strips and then put strips into each cryovial. and then freeze those cryovials indefinitely. When the patient is ready to use the tissue, we'll create this window in the peritoneum, and we will place the tissue in the peritoneum and then sew the peritoneum closed. Within 90 days, angiogenesis will occur. Blood vessels will grow to the tissue will wake up and produce hormones. The patient will ovulate through the peritoneum, and the idea is that the fallopian tube will have remained and will capture that oocyte. The other option is to decorticate or remove the cortex from the remaining ovary. So we never remove both ovaries, we always remove just the one. We suture ligate the tissue to the remaining ovary after removing the cortex to allow for angiogenesis. And then a third technique is to cut slits into the ovarian cortex and then slide this tissue that has now been thawed underneath the cortex, and then angiogenesis will allow an awakening of the tissue. There have been over 200 children born worldwide from this technology as of this publication, actually in 2021. 8,000 or more tissues have been frozen with 1,100 transplantations, and we've been able to freeze tissue prepubertally and then all the way into mid-adulthood. We don't freeze tissue beyond age 35 because we know that the follicular loss is great and the likelihood of success is low. The delivery rate is 29 to 41%. So this is a pretty decent. If you look at the other data, egg freezing, embryo freezing, 60%. So we're rapidly approaching a really comparable delivery rate. And half of the singletons that are born are conceived naturally. So actually the majority of births from this have been through natural conception, not through IVF. So patients can have intercourse and conceive after transplantation. Again, it's not contraindicated after some chemotherapy. And we know that the tissue can provide hormone function for up to 10 years. So you can imagine that a lot of patients have a discussion with us about using the tissue for hormone therapy. And our counseling to date is that we recommend using the tissue for fertility first, and then if there's tissue remaining, then using that for hormone therapy, because we have other ways to provide hormone therapy, and for some of these patients we don't have other ways to allow fertility. This slide just goes over the GnRH agonist, because we give a lot of GnRH agonist therapy in patients receiving chemotherapy, and we give it for two reasons. One, for menstrual suppression, because these patients have pancytopenia. We don't want them to have further blood loss, and so we give it for that reason. But there are some studies that have shown that it may be protective for ovarian function. And so this was a Cochrane review that looked at menstruation recovery and the incidence of premature ovarian failure and the persistence of ovulation. And they found that in these parameters, they did show a statistically significant benefit for GnRH agonists. Now, the evidence isn't great, low certainty evidence, but this is what we know. In terms of pregnancy, however, it did not reach statistical significance. So we can never counsel a patient that GnRH agonist therapy is going to improve pregnancy rates. We know that it's going to allow ovulation to persist, which may provide the patient with an opportunity in survivorship to pursue fertility within those first couple of years. But we never encourage patients to use this specifically for fertility. And the statement by ASCO is GnRH agonist appears to be effective in protecting the ovaries during chemotherapy in terms of maintenance and resumption of menstruation, prevention of treatment-related premature ovarian failure, and ovulation. Evidence for protection of fertility was insufficient and needs further investigation. And just as an aside, we're not really concerned about resumption of menstruation. That's not an indication of fertility in any rate. There was an update to this 2019 Cochrane review, and that Cochrane review showed that the data in lymphoma and breast cancer did suggest improved pregnancy rates with GnRH agonists, but because there's still some question about that data, we are using this statement here. Breast cancer patients receive GnRH agonist therapy regardless as part of their treatment. So then what are the screening recommendations for reproductive late effects? If we know that patients are going to be at risk, we know the guidelines state that they should all be counseled, we know how to stratify risk, we know what the fertility preservation options are, what are we going to do in survivorship for these patients if they pursued fertility or did not? So Children's Oncology Group long-term follow-up guidelines recommends that for patients receiving these higher risk therapies, we need to monitor their menstrual history. We need to perform Tanner staging until sexually mature, and we need to follow hormone. We need to offer hormone therapy if these patients experience ovarian failure. So in survivorship, if a patient presents to me and she has received therapies that are concerning, regardless of her menstruation pattern, I am going to assess her fertility potential with an FSH, estradiol, and an AMH. There is no standard for how often we should do that, but FSH and estradiol have been around, for time since time immemorial, and we use that to assess ovarian function. What we do know is that AMH drops before FSH rises. So waiting for the FSH to rise to show us a patient has premature ovarian insufficiency is not helpful. By the time it rises, they have ovarian failure. We can't intervene. So what we really need to do is to be able to assess this before they reach ovarian failure. And AMH at this time is the best test that we have. And that these patients should be referred to REI at any time that they are concerned about their fertility or want to be evaluated. In terms of the testing, AMH, when we draw this testing, a value less than 0.5 is considered very low. Low is 0.5 to 1. Normal is 1 to 3.5 and higher. So when we see a very low AMH, we're going to recommend that they proceed with fertility preservation in survivorship immediately. Same for this range. The issue becomes some of these patients are still young and they can't pursue egg freezing, or some patients are just not ready to undergo that or can't afford it. So monitoring these patients is what we have been doing. There's no standard of care for post-treatment monitoring in the absence of clinical signs of ovarian insufficiency. But when we see a low value, we will repeat that in 6 months or sooner. If it's stable but in the low range, we will continue to repeat that yearly. So you will see your reproductive specialist drawing AMH levels. Many oncologists draw it because they understand how to use it, and we may do that every 6 months to a year. It is not the best predictor for pregnancy, though. A patient with a low AMH of 0.5 can still conceive. And so what we're telling them is that they have a diminished reserve. It does not mean that they cannot conceive. And that's important because these patients hear, I'm infertile. And then they have unprotected intercourse. And then they conceive, and then they have an abortion. And so we need to be sure that we're not putting our patients in a situation by not properly counseling them. The message is that you have decreased fertility for sure, and we're not recommending you get an MD and a PhD and a JD before you have your children. We're recommending that you intervene in your early 20s, late 20s at the most, and as soon as possible is recommended. In terms of uterine injury after radiation, our recommendations are not great. And I'm a part of the working group for the ovarian injury and uterine injury. So I helped write these guidelines, so I'm familiar with them. And we're not great at our uterine injury. We know that TBI, pelvic radiation, spinal radiation will cause uterine injury. And there are thresholds for that. Right now, our best recommendation is high-level ultrasound of the uterus and genitourinary tract when the patient is contemplating pregnancy. This is a bit of a concern because radiation injury, fibrosis is going to set in fairly quickly. And so waiting until a patient is 25 to assess whether or not she's going to be able to carry a pregnancy is not very helpful. So we need to do more work in this area. I want to talk a little bit about sexual dysfunction. So one of the misperceptions that we have is that patients are too sick to have sex, that adolescent young adults do not have sexual experience. If they don't have sexual experience and diagnosis, then we don't need to be concerned during treatment, that cancer survivors are less likely to engage in risky health behaviors, and that AYA patients are too young to have sexual dysfunction. The truth is that patients remain sexually active during cancer treatment. And actually, 10% of patients will initiate sexual activity in the midst of treatment, whereas they were not sexually active at diagnosis. And that's a little bit like carpe diem, right? These patients feel an existential crisis, and they are wanting to experience some things. So many AYA have their sexual debut during treatment, so 59%. So actually, this is the statistic I was describing. This statistics leads to remaining sexually active. And then we know that adolescent survivors engage in risky behaviors and that contraception is important. And so we don't do a very good job of engaging counseling our patients about contraception when we see them. So 44% of patients were using contraception at the time of diagnosis, and then throughout treatment, this dropped because we didn't ask the questions. And that 20 to 50% of AYA survivors have sexual function concerns. Some of the barriers to addressing sexual dysfunction, patients report discomfort initiating conversations. They notice that we're uncomfortable, so they don't want to bring it up to make us even more uncomfortable. They're concerned about confidentiality. In terms of the oncologist and the internist, they report a lack of knowledge and experience, a lack of resources. Who do I refer to when the patient says she has dysfunction? The parents or family presence is a concern for many of the oncologists, and then concern that they're going to make the patient uncomfortable. And then the biggest concern of lack of concern about time. So in order to overcome this barrier, we do need to establish expectation for one-on-one communication with the patient throughout treatment by regularly asking the family to step out so that we can have a confidential conversation. We need to explain the reasons why we're discussing this in the first place, and this helps us to establish rapport. In terms of lack of knowledge, we don't have to be everything to all people. We can be prepared to we need to be prepared to refer to our sex and physical therapists, our urologists, our gynecologists who can help with this. There is a concern in terms of low priority. This is not a low priority. This is a high priority for patients. 20 to 80% of survivors experience sexual function concerns, and the majority report this is under addressed. And then limited time. We know that if we have regular conversations with our patients about this, that each time is less time intensive. And so how can we provide equitable care to our patients? We have all of this knowledge. We know the right thing to do. Not every institution has the team, but when there is the team, we need to be able to provide these resources to our patients. And when there isn't a team at your institution, partnering with other larger centers nearby is important. And so to do this well, we need to share core competencies. Core competencies have been published. We know how to do this. We need to continually have quality improvement of our processes to make sure we're doing the right thing. We need to educate our patients as well as providers. The more information we can give patients and allow them to advocate for themselves, the better the partnership. We need to teach our oncology providers and our primary care providers, because they are the ones seeing these patients after they exit the survivorship period. And only 40% of primary care providers report knowing how to even identify reproductive late effects, much less treat them. We need to use digital and print media to help us to reinforce the information, and then find financial resources for our patients. We need to leverage technology. Best practice advisories are helpful to help our providers remember that patients need to be offered a consultation. Opt-out referrals are the standard of care across the nation for any thing of this sort. It's better to opt out than opt in, meaning in the order sets, the option for fertility preservation consultation needs to be defaulted. And then the provider can deselect that if the patient declines after they've been offered. Using a consult email can help. We receive emails from people in different states, patients in different states all the time, who want to talk about fertility preservation. And then we have our paging system, and we use our electronic medical record for bi-directional documentation between the oncology group and the fertility group. There is an Oncofertility smart form in Epic that was created by the COG and Tyler Ketterall's group at Seattle Children's, that allows for documentation that we can all readily find. And then I highlighted survivorship care plans because this is what we don't do well. Patients go through their treatments and we don't do a really good job of explaining what the risks are to future fertility and how they can communicate that to providers who are going to see them in survivorship. And we know that when we bundle interventions, we get the best bang for our buck. So multiple checkpoints for referral, which includes the email, the pager system, the EMR. We need to minimize bias by just offering this to all of our patients, regardless of what we think their situation is, and this removes barriers. And we need to improve accountability. U.S. News and World Report does include fertility preservation for the Children's Hospital report. It does include that as a metric, and that's helping to improve accountability, but that metric is only for male patients, not female patients. And so I just want to end by saying that it takes a huge village to do this and to do this well. We have, I think this is a 21-member team, which includes oncologists, urologists, our APPs, physicians, reproductive endocrinology and infertility, internal medicine, our basic science researchers, our clinical researchers, and our data management team. So thank you for your time. And I see that there are 5 questions in the chat. So I'll just start right there.
Yeah, I'll just, Dr. Appiah, I just want to say thank you. This has been a really incredibly comprehensive talk on oncofertility. So thank you. I think we will sort of try to go through the questions briefly just to stay on time. A couple of them are bundled, if you don't mind sort of quickly addressing for patients who are receiving treatment for ALL, acute lymphoblastic leukemia. What are options after treatment has started? Specifically, how early in treatment versus maybe later in maintenance?
Perfect. So when a patient has received treatment for ALL without bone marrow transplant, then we can wait until the end of their maintenance period and then proceed with ovulation induction egg freezing because they're low risk. If a patient has received some treatment for ALL and then requires a bone marrow transplant, we will offer ovarian tissue cryopreservation after the second cycle, which tends to be about when that decision is made. If they have completed all their therapy and now they have a recurrence, we will do ovarian tissue cryopreservation at that time if they did not receive the highest risk of chemotherapy at that time.
Perfect. Moving towards transplant, because you mentioned that for a patient who is approximately 6 months after transplant, who may have labs consistent with ovarian failure, what are your thoughts on continuing to follow and remeasure in 6 months to a year versus consider starting on hormone replacement therapy?
Great. So hormone replacement therapy can be started at 6 months and beyond. I know our BMT team here is a little bit leery of that. They want us to wait a year because of the inherent risk of blood clotting in patients who have had bone marrow transplant. That is something unique here. In all of my other institutions, we're able to start ovarian hormone replacement therapy as soon as the patient is symptomatic, because we could always stop it and assess their hormonal status if necessary. But we don't want patients to suffer from the symptoms of vasomotor symptoms and genitourinary symptoms of the menopause, so we can start treatment. AMH can be drawn on any hormone therapy. So at 1 year, we will draw an AMH. We don't draw the AMH before that because it's still on its rise. So at 1 year, we will draw an AMH in all of our patients and give them an assessment at that time. If we're worried about premature menopause, we can draw the FSH and estradiol early and then treat to symptoms. So I hope that answers the questions. We can treat for menopausal symptoms and still assess for ovarian reserve, and we'll do that at year 1.
Perfect. Maybe 1 or 2 more quick questions. Do you believe that Lupron or GnRH agonists are a good fertility conservation approach for patients with ALL or similar treatments?
We believe that patients who are moderate risk and higher would benefit from that in terms of protection in adolescence, because we can then offer oocyte cryopreservation in survivorship. 1 year after survivorship, we can offer that because they will have had some protection. one can make the debate about ALL patients who are going to be at minimally increased risk, but the benefit of Lupron in that situation is menstrual suppression, and that population needs menstrual suppression more than any other population. So we would recommend they receive it for menstrual suppression, and if there is a benefit, then they'll receive it. Remember, all chemotherapeutic agents are going to affect ovarian follicles somewhat. It's just a degree, and we don't really know everyone's baseline potential when we start therapy. Someone may already have low baseline potential, so protecting ovarian function for those several years post-treatment is worth the side effects of the Lupron in our estimation.
Perfect. There are many more questions that I have and others have, but we will pause here and say...
I'm so sorry. I wasn't supposed to talk that long. And I just...
This is wonderful. So on behalf of AYAO Power and all of our participants, Dr. Appiah, we just want to say thank you. You will be invited back. So we hope you accept the invitation to come back and talk with our group. The attendees, please continue to stick with our educational curriculum. If you have questions for Dr. Appiah, you can reach out to us and we will definitely be that liaison. We'll also work on addressing some of the questions about EPIC tools to help foster getting your patients connected to fertility preservation resources. Kayla, do you want to close us out?
Kayla, can I offer one thing? I'm happy to do a Q&A at some point in a week or two if you feel like you can get your people together. I'm also happy to take the questions and do a video of the answers if you would like. That won't be a problem for me. So just some way that I can answer all these questions. If you compile them, I'll video a response and you can send them to your group.
Okay,
oh, you're on mute, Kayla.
You're on mute.
Oh man, I pulled a Mike Roth on that one. Thank you. Thank you so much. We'll make sure to compile everything. And thank you all for sticking around. Two very, very brief announcements. We did drop the survey that has been providing amazing feedback for our group as we continue to build this out, as well as topics and additional sessions. Again, a reminder, we will not be having our monthly session next month, but we are coming back in January on Thursday, January 25th on substance use and abuse. And we have about five more topics all lined up for 2024. So stick with us. We are so excited for everything that we have coming and to continue to provide to all of you. So thank you again, everyone. And we will be in touch. Have a good rest of your week.
Thank you. Take care. Bye-bye.
Bye.
That was wonderful. Thank you